everyone, my name's Jen Perry. I'm a consultant psychiatrist. I work in community rehab. I'm also the clinical lead for quality improvement. And we're here today to find out more about a quality improvement project on advanced care planning that won first prize at the recent Quality Improvement Showcase, which was part of the Resident Doctors Academic Programme.
Hi everyone, I'm Yehudit Baumfreund. I'm one of the higher trainees in old age psychiatry and I work on Garnet Ward.
Hello everyone, my name is Dr. Blair Tasenko. I'm a consultant in old age and general psychiatry and I work on Garnet Ward.
So I was wondering if you could tell us what the definition is of an advanced care plan.
Sure, so an advanced care plan is what it says on the tin really. So it's a plan that you make in advance about what care someone would want to receive in certain situations. And it's a plan that's made between the patient, their family, especially if they don't have capacity to make decisions, and also with the clinical team, the multidisciplinary team. And it's something that in general hospitals, such as the Whittington or other hospitals, they'd probably be thinking about all the time. And it's something that you would talk about as soon as you come into hospital, about what you'd want your advanced care plan to be should things get worse medically. But I think on a psychiatric ward, it's not something we're used to thinking about or talking about or really doing. And what we've kind of realised through the project is that we do need to be thinking about it, because a certain proportion of patients on Garnet Ward have very advanced dementia. They're very physically frail. So the chances of something happening medically to them while they're here is actually quite high. So we really do need a space and a proper way to be thinking about this and talking about this so that we can make these plans in advance.
So can you tell us a bit about how you got started with the QI project initially?
Yeah, absolutely. So once we'd noticed this problem, we wanted to know kind of how bad it was in sort of quantitative terms. So we sent out a survey to Garnet Ward staff, but also to doctors who cover the on-call rota in Highgate East. And what we were trying to capture is the level of confidence in making these decisions, both in hours and out of hours. And what that showed was that most people are familiar with the term advanced care plan and why someone might have one, but they weren't sure where to find a patient's advanced care plan. And scores on confidence level for making decisions about treatment escalation were quite low. So on average, they were about 3 out of 5 confidence in hours and 2 out of 5 out of hours. So that made us think this really is sort of an area where we could have change and there's definitely room for improvement. So then we were advised to speak to trust leads in this area. So we spoke to the Associate Director of Physical Health Nursing and also with the lead for Resus in A2E Solutions. And we've had lots of discussions with them, which was really helpful. Initially, they pointed us towards something called the RESPECT Proforma, which is an established advanced care plan proforma recommended by the Resus Council. But we found the problem with that was that there is a box on it saying clinical recommendations, but it's just a small box and that's all it says. And our issue that we were finding was that it might be documented somewhere, not this person shouldn't be transferred anymore, but it wasn't specific. And then if something happens, for example, if someone has a fall in the middle of the night and hurts their head, someone who is not part of their regular team, and it might be, a relatively junior resident doctor, might then have to make a call, or am I actually not sending this person over to the Whittington with a head injury? And that's a really big decision to make. And then if they go against that decision, that might cause more stress with the patient and the family and the team in the morning. So what we were, having looked at that and got the results from our survey, that led us to the intervention, which is what we really need is something that's more specific and something that has more space to really think about, proactively and preemptively think about the most common medical emergencies that happen on this ward and what should be done in those situations, so that if it does happen, someone isn't left making a decision on their own, so that if that does happen, what then happens is something that's already been thought about.
And it is very important to have this performer in an allocated place in the electronic system and also in the file of the patient in the main office. So everyone who works on the ward is aware of the documentation and they can pass this on to the doctors, the resident doctors that come during the on-call hours.
So can you tell us a bit about how you engaged the MDT in the project?
Sure. So I think because this was a problem that we noticed at handovers every morning, which is where MDT staff all attend. So at handovers, we have the medical team, we have the nursing staff, we have the psychologist and the occupational therapist. I think it was a problem and a gap that was familiar to the whole team. And then when we sent out the survey, we were really happy with the range of responses we got back. So sort of just under half the respondents were medics, which makes sense because even medics not on Garnet Ward might be looking after patients on Garnet Ward out of hours. But then half the respondents were all different members of the MDT. So we had nursing staff, support workers, psychologists, occupational therapists who all responded to the survey. So that was great to see.
Can you tell us a bit about what the aim for the project was and what your measures were?
Sure. So when we started the project, and that was last December, no patients with advanced dementia on Garnet Ward had an advanced care plan in place. So our first smart aim was to improve this to 50% of patients with advanced dementia having an advanced care plan in place by the time we next measure, which will be the coming December. Obviously, in an ideal world, we'd have 100% of patients having an advanced care plan, but we're trying to be realistic with a smart aim and acknowledge that these things take time, change takes time, and also, as we'll come on to maybe later, you've got to do it at the right point at someone's journey. You can't do it as someone walks in the door. So it might be that when we remeasure, patients aren't at the right stage to have one yet. So that's one aim. And the other aim is about increasing confidence of staff. So as I mentioned before, on our first survey, those scores were low, and we'd like to bump them each up by a point in a year's time. So have people feeling 4 out of 5 confident in making those decisions within hours, and 3 out of 5 out of hours. Obviously, we'd like everyone to feel 5 out of 5 confident all the time, but as I said, these things take time, and this is an ongoing project.
Can you tell me a bit about the interventions you made as part of your project?
Sure. So the main intervention has been an advanced care planning proforma that we've made. So our own one that we feel fits the psychiatric hospital, because we didn't feel like the existing ones out there were really capturing the gap that we were picking up specifically here. So we drafted that as an MDT. So first of all, amongst the medics in the team, we drew together the most common medical emergencies we feel like we face on the ward, to have those scenarios kind of specifically laid out on the proforma. We spoke to the nurses in charge and the nursing staff as well to check that this corroborates with their experiences. And then we also met with the doctors in the same position, but in the North Borough, so on Silver Birches, the dementia ward in Enfield, to show it to them and get their feedback. And they've added a few things to the proforma, which is really helpful. And that's also helpful later in implementing, because we want to have consistency across the trust. So it's on its fourth draft, and we're always, really happy to review it, reflect on it, and reiterate it when people come up with new things. It's definitely a work in progress.
The discussions about the advanced care plan start really early in the patient's journey, but these are mainly discussions that happen within the multidisciplinary team members. And it comes to a point during their admission on the ward where we organize meetings with the family and other members of the multidisciplinary team, where we have the discussion about the advanced care plan. It's quite a sensitive topic, and we bring the proforma during the meeting, and we try to explain to the family members and to the patient, when they have capacity to understand, about what this involves. And we provide them with clinical scenarios so they can make informed decisions about the advanced care.
And then the other part of the intervention will be that once the proforma has been kind of finalised and made official for the trust through policy, we want to educate about it. So we want to educate members of the multidisciplinary team who are looking after patients on Garnet Ward, and again, resident doctors who are looking after patients on Garnet Ward out of hours, about why we have the Performer, how to use it, where to find it in an emergency, which is really important, and the fact that it's there for constant review, so it's not set in stone and it's something that needs to be thought about and rediscussed. So that would be the other part of the intervention, is the education around it.
Can you tell us about some of the challenges you encountered in the project?
One of them is having a standardized form for advanced care plan that cannot be just used on Garnet Ward, but trust-wide, and having that as a written policy and as a document that everybody could access at any time.
Yeah, exactly. So it's weighing up the fact that we are trialing something that's new, and we're doing that under supervision and reflecting on it all the time, but weighing that up against the fact that this is a reality facing our patients on a daily basis, and there is no existing guidance for advanced care planning in this kind of scenario, so specifically in an inpatient psychiatry setting.
Can you tell us what the main learning points have been from your project?
Well, having completed a few advanced care plans here on the ward, one of the things that we have noticed that it's important to consider is when in the patient's journey to actually have the discussion about the advanced care plan. When patients come on the ward, they are in a crisis, they are very distressed. Family members and their loved ones, they are also being part of what's going on and the crisis. So it's very difficult to have this kind of discussions early on when the patients come in. So it's very important to choose, after you have seen the patients a few times and have spoken to the families, to have this discussion about the advanced care plan. And it is a very sensitive topic, and you have to think about the right way to approach with the family members. And for some of them, it's much easier to make a decision, and we'll be able to complete the form and respect their wishes and their loved one wishes. And in some other cases, they might feel that they need more time to think about the advanced care plan. And this is not a static situation. We keep an open mind, and we provide them with more information and invite them again and again whenever they are ready to make the decision about the advanced care plan.
Yeah, and I think another really important learning point from the project has been about how patients come from all different backgrounds, whether that's cultural backgrounds, religious backgrounds, and patients and their families have really different views about what they would want to happen towards the end of life. And it's really important to consider all those views so that we're really delivering, patient-centered and individualized care. I think another learning point through the project, because we have had lots of involvement from the MDT, which is great. And what we've learned is that we all come from different backgrounds as well. And we all have different sort of preconceived notions, whether because we're coming from a particular religious background or because we've had personal experiences with family members with advanced dementia. And that's why it's so important that this isn't just one person making a decision on their own in the middle of the night. This is something that we have to create a space for everyone to have their say and everyone express their wishes and what they feel would be the best in that scenario, and think about it preemptively.
Can you tell us a bit about the impact your project has had so far?
Sure. So since we've been doing the project and using this pro forma and trying to think about advanced care planning in a much more proactive way, there are two patients that really come to mind who have ended up passing away on the ward. But I think in both cases, because we thought about things sort of significantly before they did deteriorate medically, we were able to really lay down explicitly what their wishes were, what their families' wishes were, consult as an MDT, have palliative care from the Whittington coming in regularly to see them. And I think when they passed away during their admission, they passed away in the way that they wanted to and in the way that their family wanted them to. So that's been a good experience for us as the clinical team. And I think something that really stood out from both those cases was that it felt smooth. The care delivery felt smooth. It didn't feel chaotic, and it didn't feel like we were firefighting and rushing to make decisions when an emergency happened, because we'd already thought about it. But we'll know a lot more about the impact when we do our survey again after our intervention is complete, so that we can see, do more patients with advanced dementia have an ACP in place on our ward, and are clinicians feeling more confident about it?